Gonna do a little, let's see here. Okay. All right, so don't mind us if we kind of mute folks like during the meeting. I know it's hard to jump onto Teams and it has a default of having the microphone on. But so as I was saying, this is my neo dad, Dr. Rangasamy Ramanathan, who goes by Ram or Dr. Ram. He's like a one-word wizard, just like Madonna or Cher. He's also the pediatrics professor and division chief in neonatology for Cedars Sinai Children's Hospital, and a landmark at USC in building up that fellowship program there. He's an expert in respiratory diseases for neonatal, in the neonatal sphere. He's also done a ton of research, over 330 publications. He's an inventor as well, as you know, the ROM cannula. Never have I ever had one nasal breakdown after using the ROM cannula, but he's also invented a ventilator for low resource settings. It's called the ROM Smita ventilator. So innovator, inventor, researcher, scientist, and a phenomenal mentor. I can't say enough about him. So he's going to be talking to us about the chronic phase when ventilating BPD patients. So the time is yours, Dr. Ram. Thank you so much. Take it away.
Okay, thank you, Clara, for your kind introduction. So feel free to put it in the chat, your questions, and we'll have time to have a discussion. So again, first thing is when you're talking about BPD babies, bronchopulmonary dysplasia, B patient, it took, when the babies get transported to me, I always tell them it took 6-7 weeks for the baby could this stage. It's going to take 12 more, double the time for me to help the baby's lungs to heal. So you have to be patient. Oops, oh boy, an automatic or something. Okay, I hope not. If not, I can stop the clock. So objectives are, look at the changing in definitions of new BPD, understand the changes in lung mechanics, and then newer approaches to chronic phase, both invasive as well as non-invasive strategies. We all are familiar with the Northway definition, which came up in 1967. These are much more bigger babies. Chronic lung disease among survivors of severe RDS. There was no high frequency ventilation, no surfactant. These lungs were beaten up. Progressive emphysema, a lot of fibrosis due to oxygen toxicity, high ventilated pressure. Andrew Shannon from Toronto came up with this need for oxygen at 36 weeks based on a positive predictive value of 63% for abnormal pulmonary outcome at 2 years of age. And then a National Heart, Lung, Blood Institute workshop had in 2001. They separated babies less than 32 weeks versus more than 32 weeks. They're less than 32 weeks babies are the ones at the highest risk. So they said cumulative days of oxygen. The problem with this definition is nobody keeps track of oxygen days. Baby maybe for half an hour during feeding babies on oxygen. How do you count that? Is that an oxygen day? So it's never been actually validated in a clinical sense. It's based on oxygen at 36 weeks post-menstrual age. Even if the baby's on room air, baby is considered a mild BPD. If the baby requires less than 30% oxygen, moderate, and severe if the baby is on positive pressure ventilation or more than 30% oxygen. So this definition, Alan Job and Eduardo Bancalari were the lead in this workshop. It has been used for many, many years, over 24 years now. Michelle Walsh came up with a physiological BPD. Again, depending on what saturation you accept, your BPD rate may be different. So when they compared centers that accepted lower saturations, they had 10% lower BPD rate compared to centers that want higher saturation. So that also fell out of favor. From Japan, they said oxygen or respiratory support at 40 weeks was more predictive of death or abnormal level outcome rather than at 36 weeks. And then NICHD had another workshop in 2018. They removed the requirement for 28 days of oxygen prior to 36 weeks, but added a requirement for chest X-ray confirmation of parenchymal lung disease and used a severity grading of grade 1 to 3 and incorporating also newer modes of non-invasive ventilation like nasal CPAP or NIPPV. In 2019, they looked at SpO2 and PiO2 using an oxygen dissociation curve at any given point of time. Again, this is a little more complicated. Hopefully AI will help us to put this equation in the computer so it'll tell us exactly that no one is using it. And the biggest change that happened in the last 25 years is Jensen's definition. He looked at 18 different definitions, completely moved away from days on oxygen, and given the current mode of support using more and more CPAP or non-invasive ventilation, we came up with this definition: grade 1, nasal cannula oxygen less than or equal to 2 liters per minute, grade 2, nasal cannula greater than 2 liters per minute, or babies on NIPPV, and grade 3 is intubated positive pressure ventilation, regardless of days on oxygen. So when he compared 18 different definitions in this publication, he found this definition predicted best in terms of pulmonary outcome at 2 years of age and neurodermal outcome. So many now are starting to use Jensen's definition in their studies. Okay, let's take a case scenario. Hello, somebody's talking. Okay, former preterm baby, born at 24 weeks. Now the baby is 34 weeks post-menstrual age. Baby was resuscitated with nasal CPAP. NICU, baby received surfactant via Lisa, failed nasal CPAP and intubated on the 5th day. So baby had been on CPAP for the first 4 days and was placed on SIME plus pressure support. Baby failed extubation times 2, remains intubated with a PIP of 28, a PEEP of 6, and an FiO2 of 55. Chest X-ray is consistent BPD. Okay, now the question is, before I talk about it, let's look at what type of BPD the baby has. The clinical phenotype, which we're all very familiar with, and then endotype. Endotype is this baby having predominantly alveolar hyperplasia or vascular hyperplasia or a combination of both? And second thing that happens in these babies is when the alveoli are coming up in these preterm babies, the capillaries do not adherent to the alveoli. So it's called the alveolar capillary disorientation. It is like a baby with alveolar capillary dysplasia. That is one of the reasons why these babies become hypoxemic and hypercarbic. So you need to know what type of phenotype endotype the baby has. Phenotypically, we can look at the chest X-ray, look at the predominant involvement of the parenchyma, or airway disease. Airway disease, you have to do a flexible bronchoscopy to look at the airway, and I'll show you some data on that. And then BPD associated pulmonary vascular disease or pulmonary hypertension. So Ochiai et al. Had a criteria based on parenchymal lung disease, lung expansion, mosaic pattern of attenuation, intercostal bulging, cysts, bullae, blebs, cyst size, triangular subpleural opacities, distortion and thickening of the bronchovascular bundle, consolidation and interpretation of overall lung disease severity, a maximum score of 18. Again, this has not been validated in any published studies. So the other problems are airway problems. The major ones are in the central as well as peripheral airways, central airways, tracheomalacia, and bronchomalacia. This is one of the major limitations in babies with chronic BPD. They have expiratory flow limitation. When you do inspiration flow gaze in, during exhalation, when the bronchomalacia, the bronchi collapse and the baby gets gas trapped and then gets hyperinflated, and PIE gets worse, pulmonary interstitial emphysema. Rarely you see bronchial stenosis. Small airways, mucous gland hyperplasia, epithelial injury, edema, and smooth muscle proliferation. That also contributes to pulmonary hypertension that is associated with BPD. So you always want to get an echocardiogram in babies with BPD and hypoxemic respiratory failure so that you can decide should we think about using nitric oxide or sildenafil. We have 2 babies that severe BPD, both had pulmonary vascular disease associated with BPD, and we have the babies on nitric oxide and sildenafil. Bronchoconstriction, some babies do have a predominantly reactive airway disease, so these babies may respond to bronchodilators. If you give bronchodilators, the baby doesn't respond, you should stop giving it. Sometimes we put these medications and never stop taking it away from these babies. Actually, it can make it worse. Distal airspace and vasculature decreased alveolarization. I told you alveolar hyperplasia is the hallmark of new BPD. Vascular growth is also decreased, vascular hyperplasia, and then vascular remodeling. abnormal vasoreactivity. When these babies get hypoxic, they actually go into spasm and they don't relax. Impaired lymphatic function. A lot of people are focusing on a lot about lymphatic circulation because there's tremendous amount of lymphatics in the pulmonary interstitial space. When the lymphatic flow outside of the interstitial space is interrupted, then you have a lot of edema in the interstitial space, and that makes the oxygen diffusion worse. So that's another thing we need, especially babies are on high pressures, the lymph drainage becomes decreased. Control of breathing, not as much. Sleep disordered breathing or chest wall stability, especially these babies have, osteopenia, and they get what is known as rickety respiratory distress related to rickets. So sometimes they have fractures, pathological fractures, and diaphragmatic dysfunction is another area. So when we say BPD, we're always looking at lung and managing that number of other areas we need to focus on. So going back to the baby I told you, so when should we try so-called chronic phase ventilation strategy? Patient has been on intermittent mandatory ventilation for at least 4 weeks, or the baby is now at 32 weeks post-menstrual age, then you start thinking about using your strategy from acute management, like you do in RDS babies, to BPD, and not responding to conventional ventilation strategies. Bronchodilators may make it worse, so one may try and see how the baby responds. If the baby responds, you can continue. Otherwise, you don't want to give it. This came out of the BPD Collaborative, published 4 years ago. So again, we have to change how we approach these babies. If the baby has RDS, acute phase, our goal is every day. Let's wean the FiO2. Let's wean the rate. Let's wean the pressure. Okay. Treat the lung disease, RDS, right? During chronic phase, how can I support the baby to grow? Linear growth, not fat, linear growth. And treat the whole person, not just focusing on the lung. Take care of the baby's cerebral blood flow. Make sure you're giving adequate nutrition. Let the baby stay there in whatever setting you're going to go use on the chronic phase strategy, and give weeks and weeks for the baby to grow the lungs, and you don't want to keep changing. We don't even get blood gases or chest x-ray. Sometimes we do it once a week. There is no reason to get everyday labs and everyday chest x-ray on these babies. So BPD lungs are physiologically static. These patients have chronic illness and not acute illness. It's impossible for the lung function to improve quickly. Therefore, you have to be very, very patient. Severe BPD is evolving in babies during periods of incredibly rapid growth, right? And neurodevelopment. Therefore, you should focus on sending enough oxygen to brain and other organs. Mode of ventilation. That BPD lung is a multi-compartment model. It's not a homogeneous lung disease. It's a heterogeneous lung disease. There are some lung units that are fast emptying, some are long. So with increase in resistance is the dominant abnormal lung function. Airway reactivity and expiratory resistance is the most important lung function abnormality in these babies. So complete exhalation needs 5 time constants. In healthy babies, time constant is compliance times resistance. Healthy babies, 1 time constant is 0.15 second. If there is 5 time constant in the baby with BPD, we are talking about an expiratory time that's at least 0.6 to 0.8 or 1 second. If you want to have 1 second expiratory time, you also have to increase the inspiratory time to get the gas into the baby. And I'll show you what we do when you go to chronic phase ventilation. Again, see the chest x-ray, classical RDS. You don't even see the heart borders, white out lungs. Fortunately, with antenatal corticosteroids, we don't see this type, but you can still see it. Whereas BPD babies, focal hyperinflation, some atelectasis. And if you do the CT scan, you can see, PIE or nematoceles spread out everywhere, some fibrosis. So this is not a homogeneous lung disease. You can also use lung ultrasound to make the diagnosis of BPD. Here is a baby that has B lines, and they are separated. Whereas you can go to a kid with BPD, you can see pleural thickening, some areas of consolidation here, subpleural consolidation, and here is hyperinflated, and here is the CT scan. A lot of basal part of the lungs are more affected. Hi, keeps going. So again, homogeneous lung disease like RDS or meconium aspiration now has evolved into surfactant dysfunction. Then you call it as ARDS, secondary to meconium aspiration, right? That's a homogeneous lung disease where you can a smaller tidal volume, shorter inspiratory time, fast rate, and NFP, and pressure support for spontaneous breaths. If you have a heterogeneous lung disease like this, you have to use much larger tidal volume, 8 to 12 ml per kilo, a long inspiratory time, 0.5 to 0.8 seconds. We never use 0.8 seconds in a baby with RDS, right? But here, we never use 0.4 in a baby with BPD. Very slow rate, 10 to 20 ml, because you want to maintain the minute volume, which is frequency times the tidal volume. So if you decrease your rate, you have to increase to larger tidal volume. You have to make sure you give enough P to overcome the resistance. Second, to overcome the collapsibility of the bronchi or trachea, tracheomalacia or bronchomalacia, and allow the baby to breathe spontaneously as much as possible. For that spontaneous breaths, you want to give pressure support, at least 10 to 15, or you look at the spontaneous tidal volume, and if the baby is getting at least 5 to 6 ml, then you know your pressure support is sufficient. Okay, that's how you choose how much pressure support. As a rule of thumb, 1/3 to 1/2 of delta pressure, PIP minus P, could be used as a pressure support. I typically tell just put 10 centimeters in all babies above the PEEP for your pressure support for the spontaneous breaths. We look at the flow time curves. Most ventilators nowadays give you can see inspiratory flow. Expiratory flow starts as soon as the inspiratory flow ends. And here is a baby. Inspiratory flow didn't even come. The exhalation started. And before the exhalation came to zero, the next breath started. So if you have fast rate, you're going to get gas trapping. So incomplete exhalation with expiratory flow not returning to the baseline. A very simple, of all the graphs, this is a very useful graph when you're looking at on the monitor, ventilator, flow time. I want to make sure I have enough expiratory time. Look at how long it takes for these babies to come back to the flow to get out of the lung. Slow return of expiratory flow due to high expiratory resistance. So we call it as expiratory flow limitation. Gas got in, and during exhalation, the diameter becomes smaller. Therefore, it has to take a longer time for the gas to come out. With increase in rate, you will definitely going to cause gas trapping. That is why in a baby with BPD, you cannot be using the rate more than 20 or maybe 25, not more than that. Here is an example from Shepard's publication. This is the total tidal volume in ml, 30 ml, fast space. These are the dark circles. You can see this alveoli or lung unit emptied within 1 second. But the one that are slow space took 3 seconds. So we have an inspiratory time of 0.5 second, the rate of 17. The first compliance is pretty much the same, 0.5 ml. Resistance is 0.2 centimeters or ml per second. Time constant, compliance times resistance 0.1 second. The slow space, the gray circles, has compliance of 0.8, resistance of 0.7, 75 centimeters per liter, time constant 0.6. So if you have exhalation depends entirely on the slow space as the fast space is completed, emptied within 1 second. This is taking almost 3.5 seconds. Okay, so that's 4.5 seconds per breath. So that's where you need to have a rate that is like 20 rate will give you 3 seconds per breath, right? So that's the reason you have to use slow rate. So this is what they use at CHOPS, the Children's Hospital of Philadelphia, where it's a BPD center. Jensen was there. He's now in Stanford. So they use volume targeted synchronized IMV with a pressure support ventilation. The tidal volume 8 to 12 ml per kilo. Peak inspiratory pressure, they really don't worry. They routinely use 30 to 40 centimeters of PIP and no maximum PIP. If the baby needs 50, let the ventilator use 50 centimeters to deliver this tidal volume. And there are leaks. That's one problem with these babies is if the huge leaks, then you cannot use volume control mode or volume guarantee mode. You have to use a pressure control. So again, the rate less than 20 in inspiratory time, they often use 0.6 to 0.8 seconds. Pressure support with short inspiratory times associated with spontaneous breaths will address the fast compartment. And then most important one is to optimize the PEEP. You need to make sure the trachea and bronchi does not collapse. So let's take a second case. 26 weeks, this is a baby that's transported to us, 890 gram at birth, born on May 10th, male baby, placental histology, acute chorioamnionitis and acute phenicitis. 2 doses of surfactant were given. Initially, baby was on NIPPB for first 8 days, and then baby failed and got intubated, was placed on volume guarantee, assist control, and then switched to high-frequency oscillatory ventilation. Never needed, fortunately, PDA. We can't blame it on the PDA. Status post 3 courses of dexamethasone, the DOT treatment for BPD, and continued to have severe hypoxemic respiratory failure and 100% oxygen and severe BPD. And baby had an episode of Klebsiella pneumonia and was given Xopenex and Pulmicort treatment. Transported to us at 7 weeks of age, post-menstrual age of 33 weeks on high-frequency percussive ventilation. So when our team went to pick up this baby who was on oscillator and 100%, we transported the baby on the high-frequency percussive ventilation, which is very good for transports, and on 100% oxygen. And baby stayed for 5 days in our unit. We couldn't wean. We switched the baby to high-frequency jet ventilation. We started after echocardiogram showed pulmonary hypertension. We started the baby on INO and then added sildenafil, and we were able to wean the FiO2 to around 60 to 70%. And then transitioned on 7/8 last week to chronic phase ventilation when the baby was at 34 weeks post-menstrual age. Here is a pulmonary function that they did using lung mechanics and PEEP titration in, again, Jensen's publication here. So they looked at, this is the compliance line, this is the resistance line, and optimal PEEP in this baby was 20 centimeters. So I've never used this 20 centimeters before, okay, until I saw this publication, talking to BPD colleagues, BPD center colleagues. Now they are not afraid of using high PEEP if that's what it takes to get the lowest resistance. So this is one of our babies. We did the PEEP titration. We had a flexible bronchoscopy. This is my pulmonologist helping me. There's another pulmonologist trained at CHLA, Dr. Derek, Dr. Irina, my respiratory therapist. This is a newer flexible bronchoscope, and you know this guy. So it's 2.2. We can easily go into a 3.0 ET tube. So this is the third bronchoscopy we did in our unit here at Cedars. And this is at the PEEP at 16 to 18. You can see when we increase the PEEP to 20, the bronchi, left mainstem and right mainstem bronchi, so nicely opened up. So based on this flexible bronchoscopy, we chose baby was on 17 PEEP before we did the bronchoscopy. We went to 20 centimeters and we were able to drop within few minutes to 40 FiO2 40. Here is a video. You can see how collapsible it is. Look at that. This is at 16, then we went to 18, it still didn't change. And then we went to 20, you can see the collapsibility is decreased. This is the pulsations from the vessels, but the airway, bronchi, left mainstem bronchi stayed open. So that's how you titrate. I think when you have technology and tools available, we should make use of it rather than blindly going up on the pressure. I understand this may not be available in every unit, but I think at least BPD centers or referral centers should, and neonatologists should be able to do flexible bronchoscopy because we may not have pulmonologists available everywhere. I think working with the pulmonologist, neonatologist, so-called the BPD team will make a huge impact in improving the outcome for these babies. At least I have 3 babies that were transported to me just for tracheostomy, and we avoided tracheostomy in all 3 babies. These are not the babies. I'm hoping we will avoid tracheostomy in this baby. I already have 2 babies that were particularly sent to us for tracheostomy, and one of them went home. The other one is on room air at 2 liters flow. I'm going to go down, and now that baby will go home. So carbon dioxide removal, minute ventilation, minute volume, which is frequency times the tidal volume minus the dead space. So if the minute volume is 200 to 300 ml per kilo per minute, in normal healthy babies, breathing at a rate of 40, a tidal volume of 6 minus the dead space of 2, it's 160. But babies with BPD, they have anatomical dead space and alveolar dead space. Therefore, their minute volume to maintain CO2 in the normal range, or even in permissive hypercapnia, they need a lot more minute volume. So if you set a rate at 17, you have to have a tidal volume of 12 to 18 ml. If you want to get 300 ml, you need to get 18 ml of tidal volume dialed up. If you use fast rates in severe BPD, patient becomes agitated, tachypnic, develops air hunger, and we call babies fighting the machine. We keep giving more sedation. You need to minimize the sedation in these babies with BPD. Okay, so first thing we do, babies agitated, we go up on the rate. Drop the rate, actually baby becomes more comfortable. A small percentage of babies may have so-called restrictive lung disease, where they may respond to small tidal volumes and fast rate, but they're very small percentage of the babies need small tidal volume and higher rate, like we use in babies with RDS. When the baby is stable, focus on nutrition, not on weaning, until the FiO2 is consistently below 40% oxygen. So if there are leaks, you could upsize the endotracheal tube when the leak is around 35% or more. Most ventilator people will say, oh, my ventilator can compensate up to 60, 70% leak. That's not true. So if the leak is more, you have to upsize the tube. Use of the cuffed endotracheal tube is becoming more popular, micro cuffed endotracheal tubes in babies, even in preterm babies during RDS phase. With the Murphy eye, this is the Murphy eye, due to concern for acute obstruction, when Murphy is not present. So this is a cuffed one. Anesthesiologists would always love to have cuffed endotracheal tubes, right? Because they want to control the volume with anesthesia machines. When ventilators, they want to make sure that giving the volume, right? Especially cardiac anesthesiologists or cardiothoracic anesthesiologists, they always will intubate the baby with a cuffed endotracheal tube. So we have some cuffed endotracheal tubes in our unit. Occasionally we use that. When the leak is less than 35%, you can do volume targeted, pressure controlled mode, or you could use assist control to support every breath to maximize patient ventilator synchrony and also allow the baby to grow. Growth means linear growth. Our baby actually was gaining too much weight. So we actually cut on the calorie today from 24 calories to 20 calories after talking to the nutrition team. So this is a retrospective observation study from 202 babies from Indianapolis, patients less than 29 weeks. If they were intubated at 4 weeks of age, the goal is to reduce tracheostomy rate and length of stay. So they had a neonatologist, pediatric pulmonologist review the patient course every week, recommend strategies to minimize gas trapping with adequate PEEP, avoiding high respiratory rate, and ensure complete exhalation, making sure on the flow time curve, the expiratory flow comes back to 0 before the next breath starts. They did a dynamic bronchoscopy, as we did here, through an ET tube by a pulmonologist for PEEP titration. Again, neonatologists in many centers are getting comfortable doing this. But if you have a pulmonologist, you can ask them to do it for sure. This is before the BPD team was established, after the BPD team was established. Similar gestational age at admission varied from 0 to 62 days. Post-menstrual age at admission, 27 weeks. Tracheostomy, 40%. Before they had this BPD team, this chronic phase ventilation strategy, and look at that, 13% after they established the BPD team. Length of stay was shorter, because if you have away on tracheostomy, they're going to stay longer, right? Discharge home on room air, 5 babies versus 13 babies. Even though numbers are high, not statistically significant. So clearly, you can, if you're patient, you work with a pulmonologist, use the chronic phase ventilation strategy, you can minimize tracheostomy for sure. So when do you extubate these babies? No airway anomalies, growing well, FiO2 is consistently less than 40, at least for 48 hours, no recent escalation of respiratory support, positive weight trend, and good linear growth on Z curve, full enteral feeds, no surgery planned for the next 72 hours, like hernia repair or something, no ROP examination on the day of extubation, no active infections, all needed extubation medications have been ordered, and no recent extubation failures. And then everybody agrees that the baby is ready for extubation. Slow weaning, okay, slow weaning. Okay, that's about invasive ventilation. Very quickly, I'm going to go to non-invasive ventilation, which is what I'm interested in, a lot more than invasive ventilation. So you can do chronic nasal high-frequency oscillatory ventilation using sensor medics, chronic NIPPV, or chronic NIPPV plus adding nasal high-frequency jet ventilation. We started a few years ago. This is the first time I did nasal high-frequency oscillatory ventilation. A 25-weeker, ex-25-weeker BPD sent home from another NICU on sildenafil, admitted with burns, accidental burns, and in hypoxic respiratory failure. Is placed on the RAM cannula attached to the high-frequency oscillator. You can see the nitric oxide was in sildenafil, Maple-X dressing, and the baby went home after 3 weeks in our NICU at LA County Medical Center. Okay, my nurses were saying you could see the amplitude is 44 amplitude, mean error per 17, 16 and a half. We used an I time 1:1, 50% I time, and you can see the hertz was very low, 4 hertz. We never use 4 hertz in babies with RDS, right? 10 hertz, 12 hertz, maybe 8 hertz. We have to use large tidal volume, therefore we dropped the hertz to 4. And the nurses were telling me baby's shaking too much. I said, okay, let's try the jet. So this is what we did. This is a baby that for 24 weeks, 4 weeks old on NIPPV, didn't want to intubate the baby. The only time the baby was intubated to get surfactant was in 28/8. FiO2 was 28 on the RAM cannula we used. Then we adapted to a high frequency jet plus the NIPPV. You can see jet PF of 40, rate of 360. We increase the jet valve on time to 0.03 seconds, that is 30 milliseconds. IE ratio 1 to 4.5. This baby was on this nasal high frequency jet ventilation for about a week, or 14 days, and then baby was extubated, went home on room air. So we got Boulder. This is Jessica Keel, who works at Kaiser Downey. Theo, one of my other fellows, Robina Kayabia, Dr. Biniwali. We published a paper in 2021 Journal of Neonatology looking at chronic NIPPV with nasal high-frequency jet ventilation. This is our retrospective case series. We had 18 patients, and we were able to avoid intubation in these babies. Now we started after I moved to Cedars Sinai. We introduced the nasal jet. This is a triplet, one of the triplets born at 23 weeks, extubated to NIPPV on March last year. And then jet was added in June when I started officially here. And PIP was 46, PEEP of 16. And then jet PIP, that's the maximum I could go, is 50 centimeters. Just park the baby there. Don't wean. Just every day come and assess the baby. And respiratory therapist said, but Dr. Ram only been this one, AVIA settings and not chest pressures. So mean PMA was 32 weeks with a mean day of like 49 days, average weight gain 1980 grams. Initial jet rate was 240, went up to 360, maximum we used 50 PIP. This baby went home on half a liter nasal cannula. Then my former fellow, my kid, Mark Weems in Tennessee, they started using chronic phase NIPPV, okay? And they used 45 PIP over 14, rate of 40, and I time of 0.6 seconds, and they slow weaning after a month. They showed less tracheostomy and shorter length of stay. Then I spoke to him, I visited his NICU. He said now they're using 55 over 15, okay, during NIPPV. He was one of the babies that went home without a tracheostomy. In the chronic phase, non-invasive ventilation strategy. We submitted the paper, it's being revised. We resubmitted with the reviewers' comments. Hopefully it'll get accepted soon, published soon. So again, he showed that Only 7 of the 11 breaths are at least partially supported during NIPPV. The set rate of 25 breaths per minute, inspiratory rate of 0.4 seconds, only 3 out of the 11 breaths are partially supported. That's why we have to use faster rate. When the rate was set at 40, inspiratory rate 0.6 seconds, 7 out of the 11 babies were, 11 breaths were at least partially supported from the NIPPV breaths. Sedation. This is a nationwide children's guideline. Again, don't keep drawing labs no more than once per week. Even in sick babies, just follow transcutaneous and saturation. Use of such cuff blood pressure, maybe once a day, not every shift. Any form of sedation you have to minimize. Maximize parents holding baby regardless of the respiratory support, oral feedings as soon as feasible, interactive therapies and all types of therapies, and non-pharmacological approach to calming the baby. If you want to use drugs for sedation, one thing I will say, dexmedetomidine is getting increasingly abused in the neonatology, including in my unit, but that's Precedex getting more popular. Don't use midazolam or Versed. You can use fentanyl or morphine. Sometimes the baby has been on it for a long time, then we switch to clonidine or methadone. This is the conversion. It's published, so you can get this information. In this one of our babies, the triplets, happily lying down, really sleeping. You can probe. This is on high flow nasal cannula after the baby was weaned to 3 liters per minute. And this obviously family gave me the permission to show this. Saying hello, thank you for avoiding tracheostomy in me. That's what the baby said. So in summary, when to consider chronic phase ventilation strategy after 4 to 6 weeks of invasive mechanical ventilation, use larger tidal volume, long inspiratory time, manage the airway obstruction with high PEEP, slow rate, PEEP titration if you have the facility to do that, and then pulmonary function testing to optimize ventilatory management. So here we use a lot at Cedars, Sinai, we use a lot of NIPP plus nasal high frequency ventilation. Definitely we need to use higher pressure. Thank you very much.
Thank you, Dr. Baum. Thank you so much. We've already got questions. Oh, lots of clapping too. Before we move on into the Q&A section, I neglected to ask about the many grants, research projects, and or speaker status that you have, because this is a CME event. Would you just review that for us, like very briefly, one line? Yeah.
I already sent that disclosure. So I get research grants from KC USA, the surfactant distributor. I get from Medtronics for studies on pulse oximetry. I get ROM Cannula Neotech. I'm a consultant and I receive royalties. If I get any honorarium, I donate all of that to charity. 100%. And making your ventilator for low resource area. Yeah. Yes. Okay. Yeah. Inventor, innovator, researcher, scientist. Okay. Well, I'm going to go with our first question here. We have how we determine the optimal PEEP. How should I adjust PEEP in a baby with a chest X-ray showing patchy atelectasis, but also hyperinflation? That's the first part. Well, let's start there. So it's a good question. So if you have the baby on conventional ventilator on the subacute or acute phase of RDS management, you're switching to chronic phase, most of them you should start around 10 or 12 PEEP. And then look at the FiO2 and keep tight going up and up and up. These babies don't get into pneumothorax, knock on wood, because this lung is so stiff. They're not going to transmit that much pressure. Most of the pressure is taken to open up the trachea and bronchi. So I would I'll keep increasing, pull a chair, sit down at the bedside, go up on the PEEP, 10, 11, 12, or if you start at 12, 13, 14, 15. Once you see the saturation goes up and then you go up more, the saturation will start to come down. That means you are overinflating. Then you come by 1 or 2 centimeters below and park there. It's dynamic, therefore you need to adjust it. So that's what I do. I start when we didn't have the PEEP titration with the bronchoscopy, we just go up and then you make sure you are in the deflation limb of the pressure volume curve. The only way you know that is to sit down and go up on the PEP PEEP 1 or 2 centimeters and see what the baby responds. So the baby saturation goes up, that means your PEEP is not enough. If baby saturation starts to drop, then you have to start dropping the PEEP or mean airway pressure. Sometimes babies are on high frequency. Nobody wants to drop the mean airway pressure. You should drop it if the baby's not responding and hypoxic. That's what I would do. Yeah.
So drop it if you overshoot, but make sure that you're adequately expanded.
Even though focal hyperinflation, you want to use the PEEP to avoid gas trapping and treating the trachea and bronchi airway disease.
The large airway disease, yes. Yeah. That is a very important point, particularly because most of us are not certified or learning to do flex bronch as you are.
No, I mean, I'm just learning, right? So, but most of the neonatologists, including me, we are afraid of the PEEP. I mean, I didn't use 20, as I said. It's the first time I'm using 20 in an intubated baby in my entire life, which is a long 40 plus years of neonatology. So now that I have, and I've read, I've seen what other people, BPD centers are doing, then I said, okay, then we should optimize it. So change our practice. Because I'm still doing the acute RDS like babies, right? So now we have gone to chronic phase. So you shouldn't be afraid of using higher PEEP.
So spoken from the ultimate lifelong learner here. We have the second part of this question was, is there any benefit for long-term use of nebulized Openex and or albuterol?
There is no data on diuretics. And actually I gave a grand rounds on diuretics. And at the end of the talk said, do not use diuretics. So, but we all use it. So no, pulmonologists would love it. I think the baby is tolerating Xopenex and, not tachycardic. And the responding, you're able to see the CO changes in the TCOM. Continue. Sometimes we use, in this baby, I'm only using twice a day, not 4 times a day.
Yeah, there was some, I heard a talk many, many years ago from Bill Bennett's over at Stanford, and he had said the same thing that you had said. If it works, it works, but really in most cases, it will kind of exaggerate the large airway collapse and hyperreactivity of the airways. And so best not to especially on a long-term basis. Our next question here we have from Dr. Bont. What does why does BPD incidence vary from one level 3 NICU to another level NICU? Could it be consistent?
It depends on the number of babies. If you have a lot of tiny babies born in your center, you are going to have higher BPD. No question about that. BPD is the only disease that has not come down in the NICHD publication, Barbara published, right? So we had gotten better with less IVH, less ROP, less neck, but the BPD is there, unfortunately. So I think the center to center variation depends on how many of babies are micropreemies less than 27 weeks. If you have a lot of them, you're going to have higher risk for BPD. And also, if you transfer the baby out to another center, that BPD blame goes to the other center, not to you. So I don't have BPD. I tell them when I was at Children's, I say, I have a lot of BPD because all they came from my friends like you. I tell them. Somebody says, I don't have BPD. I said, well, either you're not taking care of micropreemies or you send the babies out. We have to be honest, okay? We have to be honest, and there's no use in saying we don't have BPD. The only way you don't have BPD is you're not treating smaller babies, sickest babies at higher risk for BPD. I always tell, we have BPD, we need to work on how to decrease it. That's why we are doing a big study, a multinational study, on using IGF-1 plus binding protein 3. It's going to be a major, major change. It's the first preventive therapy, if it works. In phase 2 studies, it has worked. 53% reduction in BPD. We are hoping that. So it's 16 centers in the US, 4 in Japan, 3 in Australia, and many in Europe. And I'm the global lead investigator for that study. Oh, that's another disclosure from Oak Hill Bio. I get only research grant. So I have a number of research grants that I get support. I have from the Research Network in Canadian. We are starting the Australian research network. They wanted us to participate in Surface Up trial, which is using LMA in babies over 32 weeks to serve the babies. Yeah,
that's amazing. The growth, or I'm sorry, the growth factor. What was it that you're giving? That's preventative.
Insulin-like growth factor on IGF-1. It's a continuous IV infusion, very short half-life. And babies, the BP, so babies get the IGF-1 from the mom, and then their liver doesn't start to synthesize until 30-week gestation. So
and this will be given preemptively, is that correct? Kind of like vitamin A?
Prophylactically from day one. Within 24 hours, baby gets randomized to placebo, or not placebo, standard care versus continuous IV infusion. So we already recruited the upper half of the baby, higher gestational age. Now we are recruiting 23, 24, and 25 weeks gestation group. Yeah.
Amazing. We've got so many more questions coming in, so I'll go with the next one here. For extremely low gestational age neonates, what is your experience in preventing BPD? Recommending maybe starting with the high frequency, it says ventilator. So do we mean maybe jet and or oscillator or conventional during the RDS phase?
No, I think in micro preemies, 23, 24, 25, 26 weeks, we do exactly what Iowa does. We do first intention high frequency jet. If the baby is intubated, we try not to intubate. We do NIPPV and nasal jet. But if the baby is intubated in the DR or for surfactant and couldn't extubate, then we do first intention jet. The settings are exactly what they do. Dr. Klein recommends. Yeah, we have a guideline on first intention jet. So we don't use oscillator for two reasons. It's much easier for us to manage, keep the baby in midline for IVH prevention, and skin to skin. We do a lot of skin to skin here at Cedars. So it's much easier to, we say, jetting our way to skin or kangaroo can. So yeah, we do. We rarely use oscillator. I haven't used oscillator in the last year, except two babies that are small babies. That
jetting your way to kangaroo care. We'll remember that. You had a slide earlier about the 26-weeker who was transferred over to you at about 7 weeks, and then the baby was on one mode of ventilation and then was transitioned over to the jet. Is that right?
Yes.
Could I just ask you about what that thought process was to put this older, I guess now would be a 33-weeker, putting on the jet?
Yeah. So number one mode of ventilation doesn't work in all babies. So one mode is not working. You need to start thinking about maybe I should try a different mode of ventilation. That's the reason. This baby came from a center that didn't have a jet, only had oscillator. And this baby has been an oscillator on 100% oxygen. So as soon as the baby came here, we said, let's try the jet. We had it on oscillator. We said, let's try the jet. So we used the jet, very low rate, like 240, and a little bit longer inspiratory time, 0.22, and we are able to bring down the FiO2 to 60 to 70%. And then we had a peep of 16 to 17, then we increased to 20, and that we are able to wean. So baby is still on the jet, high frequency jet. So jet not only works in acute babies, even in chronic babies, but you shouldn't be afraid to use higher pressure.
Excellent. Yes. We love the jet. Okay. Our next question is, let's see here. Our practice has been more aggressive with using higher non-invasive pressures in the 30s over teens. So we've run into instances where we end up with feeding intolerance. Do you have any advice? Maybe reintubate and J feeds. What are your thoughts there?
No, we don't. I mean, every baby gets a nasal CPAP belly, right? CPAP belly, whether it's NIPP or CPAP, it's the same amount. So even when we're using 50 or 45 and 50 PIP on the NIPPV, we have to vent for sure. So we give feeds over an hour and a half or two if there is reflux issue, but then give 1 hour for to vent and then aspirate. We don't even aspirate, just vent the air and then we start feeds again. If we're on continuous feedings, then it becomes an issue. So yeah, we have not seen higher incidence of abdominal distension and feeding intolerance compared to just CPAP or lower pressure. So we are not afraid to go up on the pressures, especially in babies after 2 weeks of age. We use high pressures. We have 85, 38. But again, we add jet now, nasal jet, that helps us to not use high pressures on the NIPPV. So now we need the NIPPV down to 22 or 24, minimize the abdominal distension, use the jet to ventilate. That's the advantage of combining jet, nasal jet with NIPPV.
Could you run us through the adjustment and settings that we might need to be aware of if we decide to go with the nasal jet
Yeah, that's
versus integrated jet?
Yeah, we published that. Yeah, here's one of our babies on NIPPV. Nasal jet, you see how much PIP I'm using? I'm using 40. So I didn't want to go more than 28 because that won't increase the abdominal distension, because that's given for 500 milliseconds, 0.5. Whereas I can use the jet to ventilate the baby. I can use the NIPPV to maintain the oxygenation. That's what we did.
So it looks like it's 40 over, is that 9?
9, yeah.
40 over 9, 360. And you had mentioned that you went up on the I time to 0.03. Is that usually what we should do with a non-invasive version?
Yeah, because you're not transmitting all the pressure, right? So if you want to use the timing is everything. Another one we call timing is everything, inspiratory timing. You have to use long inspiratory time, just like we do on the ISIME on chronic phase intubated babies, 0.6 or 0.8. You have to increase your valve on time, jet valve on time to 30 milliseconds. You still have 1 to 5 IE ratio, or 1 to 4.5. So high jet pressures, just use primarily jet to ventilate the baby. So you don't have to use high pressure on the NIPPV. That's basically the idea.
Gentle ventilation. Yeah. Daniel, I feel like you might have answered the second part of your question, knowing that Dr. Ram is a big proponent of NIV. He makes a note here about Iowa and their reports of keeping their micropreemies intubated for many, many weeks, even a few months. So is there a gestational age or weight where you would do this?
I'm a guy
I feel like I can answer this for you.
I love to extubate. I don't like to intubate. When the baby gets intubated, I get depressed. So no, we look for extubation criteria, which is the delta pressure is, babies on 20/8 or delta pressure is between 12 to 15 on the jet. Then I extubate the baby to NIPPV. Yeah, so we not to CPAP. Even Iowa does in their publication. They've said they extubate to NIPPV. They also use the RAM cannula there. Yeah. So,
excellent. Monitoring the delta V.
Yeah, their thing is they showed that in a publication that the babies failed jet, then more complication. So they wanted to make sure that the baby can be extubated successfully. They don't like jet failures. That's Dr. Klein's group, and they have very good results. I cannot argue with that. They have low stomach BPD, their PDA management, their fluid management, everything is completely different than what they use 300 ml per kilo per day. They don't use no humidity. She says, I want the skin to mature. If you use humidity, skin maturation is delayed and your risk for fungal sepsis. They use 2.5, D 2.5, 300 ml per kilo per day of fluids routinely in micropreemies, which we don't. So we're thinking about it, we have gone there. Yeah.
Yeah. Okay. That's a little different. Yeah. So, okay. But overall, we don't like jet failures. So we've got some questions about steroids here. When would you consider treating with steroids, and what are your thoughts about multiple courses versus just the one and the timing?
Yeah, so we are using the BPD calculator, NICHD BPD calculator. If the risk is, very recent publication from Lex Doyle's group showed that for every 10% increase in BPD rate, if you use steroids, you reduce the risk for abnormal survival without you increase survival without cerebral palsy by 3%. We actually add a lot. So babies 2 weeks old or beyond, more than 2 weeks old, and the estimated BPD calculator is more than 50%. That's our guideline. We start that DART. And there's also another systematic review that showed the cumulative dose higher, up to even 4 milligrams, is assured better outcome. So now we have used some babies 3 to 4 courses of DART, very rarely, but most of the time we do use DART. If you look at the publication from JAMA by Dr. Lex Doyle last year, clearly says that if you estimated BPD is less than 30%, then there's more harm. Don't use the dexamethasone. But if it's more than 70% clearly, and we looked at moderate to severe BPD, the calculator plus death. We had 50% death and then 45 or 50% of risk of BPD. So we clearly use the 50% as a cutoff. 70% I think is too late. And higher doses seems to be actually beneficial, not as toxic, as long as you do not use it before 8 days of age. And we don't even do that. The other thing that we have gotten into is babies on NIPPV and babies on the jet. There are no guidelines on what to do. So we agree. And about 2 to 4% of the neonatologists in the country now are using DART for babies on non-invasive ventilation. So again, if you plug it in and you put nasal jet, the risk goes up, right? It just jet, it doesn't the nasal jet. So our guidelines are babies on non-invasive ventilation plus nasal jet, and the FIO.
Oh. Wait a minute. Wait, sorry, Dr. Ram, I think you're somehow were muted. So, oh dear. Let's see here.
You have to unmute me. Okay.
Oh, there you go. Okay.
Yeah. So the question was, I don't have a jet. Can I use oscillator? Yes, but you cannot use the backup rate. You can't use NIPPV plus the oscillator, right? It's all connected to one. And you don't need to. If you're using oscillator for nasal oscillation, you can do that. A guy in Cape Town, he calls it NINO, non-invasive nasal oscillation. Every baby he gets admitted, he puts them on the cannula, attaches the oscillator, and goes home. So you can do NINO. Just the baby shakes a little bit more. Otherwise, it can. Yeah.
We could go back one question regarding the delta P and the extubation criteria versus using the mean airway pressure. Could you go into a little bit more granular detail about why the delta P is more helpful for extubation?
Yeah, I mean, PEEP, as long as the PEEP is less than 10 on the first intention jet, the PEEP is less than 10, 8 to 10. And your delta pressure, which was primary driver for ventilation, if that is 15 to 18, then the baby is ready for extubation. That's what we do.
Okay. So ventilation, and because we can deliver PEEP in so many other different ways. Yeah. And then did you already answer? Sorry, I missed it because we were muted here about the this is what you're talking about, the NINO with the jet versus the oscillator, and what settings you would recommend using the oscillator and NIV, like non-invasive oscillator?
Yeah, if you're using nasal oscillation for chronic babies, mean airway pressure is the same, whatever the baby needs it, right? You titrate up and down. The hertz, you need to use lower hertz, 6 hertz. Sometimes we have used as low as 4 hertz in that baby that I showed you. Typically, we start at 7 hertz and keep going down to 6 or 5. So right now we have a baby bad that got septic in bad ARDS. So we put the baby on the oscillator, and he's on 6 hertz today. And abdominal distension. So from possible, not neck, but it looks like colonic colitis. So that baby is on an oscillator. Yeah, you have to use lower hertz.
Yeah.
So you could consider increasing the jet to IE ratio 1 to 1. And so 33% cycle time on the oscillator, you go to 50% cycle time.
Okay. So that frequency is the biggest difference in the game changer.
Yeah, and then of course amplitude depending on the chest wall, chest vibration. Yeah.
So just going back again about the bronchoscopy, for those of us who don't do it, maybe don't have it very easily or quickly, the clinical markers to guide weaning without or adjusting perhaps the pressures without flex bronch. What do you think is the strongest? Chest X-ray, FiO2 need. You kind of talked about real-time changes with saturation response.
Yeah, saturation and FiO2. I that's the only thing. I don't need to get chest X-ray. We don't do it. We minimize it. We're thinking about adding lung ultrasound to follow these babies, but our group is still not competent or comfortable. So we're slowly starting to train them to do lung ultrasound. But if you have some champion in your group that loves lung ultrasound. I think there's more and more data that lung ultrasound can be used to minimize radiation, both in our RDS babies and BPD babies. So we should consider doing that. So I just use the FiO2 and the saturation, titrate my peak. Yeah.
Excellent. Excellent. I had a couple questions just to emphasize here. When you say patient, meaning slow wean patient with our BPD patients,
Yeah.
it sounds like you mean months.
Weeks.
Like
weeks.
weeks. Okay. Weeks. Okay.
Yeah.
Because that length of stay on that Frontier study showed 153 days was the mean stay. So that's months in terms of staying, but weeks in terms of
Changing
settings. Okay, perfect.
Yeah.
Okay.
I mean, the average age of tracheostomy is 50 weeks, 46 to 52 weeks post-menstrual age.
Okay.
That's most of the centers are doing tracheostomy, right? Some centers that are aggressive want to do it at 46 weeks or 44 weeks. Majority of the BPD centers are now going towards more and more 50 to 52 weeks post-menstrual age. That's 12 weeks. That's 3 to 4 months, right? So that's where the 120 plus days comes. I
that
would
makes sense.
have the baby stay a little longer in the NICU than send the baby on tracheostomy. It's not easy for the families or for the baby. Impossible, especially if they have other children, forget it. So they're very happy, these babies that come to us, and I show them we can avoid tracheostomy, and they don't mind staying. I mean, some of them have come from Antelope Valley, long distance. We have one baby from Santa Maria, 152 miles from here, one way. So we give them, Ronald McDonald's house or somewhere, support the family, and they see the baby changing, because they told the other hospital this baby is going for a possible tracheostomy. Here is a guy group that's doing less and less tracheostomy, and even at Children's, they didn't believe when we started NIPPV there, pulmonologists. Then they saw the results, and they do a lot more NIPPV there at Children's LA. Dr. Prabhu Iyer is their pulmonary guy. He works a lot on pulmonary function testing, and he has visited a BPD unit at Philadelphia. So actually, I'm going to invite him to talk to my. He uses electrical impedance tomography, EIT. That tells you what of the lung is very non-invasive. So we are going to introduce that in our NICU. Yeah.
Oh, fantastic. That's phenomenal.
That's another technique you can use to optimize the PEEP using EIP. It's non-invasive, just a band. So very easy to see which part of the lung is not recruited. You keep going up on the PEEP, you can see recruitment. So without flexible bronchoscopy, you can do that. That's a very good tool, EIT. A lot of ventilators now can use EIT.
Okay. The Servo I or the Servo N? Could you?
We use Hamilton here, so I hope Hamilton.
Not sure.
Before I came, they just changed to Hamilton C6. Yeah.
I just want to reiterate that you did some of the earliest non-invasive ventilation studies back in the, is it 80s, 90s?
Early 90s.
I think back in 91 is when I.
I was like a young faculty.
And now it's finally spreading, so it's becoming more, very commonplace. The last two questions, or maybe just a reiteration, you used to call the Brom cannula or, non-invasive ventilation like a birth to discharge cannula, and that the rate, the babies could go to college on the rate, which was kind of a sarcastic way of saying, don't touch the rate.
Don't be in the rate. Yes.
Don't.
Because
and then
there are two things it does. It promotes decrease the work of breathing. Second, babies are not truly apneic. They get shallow respiration hypopnea. So by giving the rate, they have less desaturation episodes. Third, the nasopharynx is not exposed physiologically to high pressure. So if I can get away with the least amount of PIP, I would like to use that. That's why I don't mean the rate.
So keep the rate. Last thing, as long as we've got another question. What's your opinion about using hydrochlorothiazide and spironolactone routinely in cases of BPD? You
No.
mentioned quickly. No.
I mean, you use that, and then baby gets hyponatremic, hypochloremic. We start sodium chloride, potassium chloride, and then you keep chasing. So what we do in the baby that has pulmonary edema, and X-ray wise, we say, okay, let's try a 3-day or 2-day basics. And the baby gets better, we wait. And then baby keeps doing the cycle again next week. Then we'll do just a week or 10 days of diuretics. We just use diural. You don't even aldactone that much anymore. So, yeah, next time if you invite me, I'll talk about diuretic use and that we use in BPD kids.
Ooh, okay. Thank you. You're on. Yeah. So
Okay.
so it sounds like intermittent, sporadic, short, brief
Yeah.
spouts.
So
Yes.
minimize as much as possible the use of diuretics.
Slow weaning and focus on nutrition.
Yeah.
Okay. So the last thing is book him now. I will get you on the books now. May we have a copy of your PDF in case someone asks, because I feel like someone's going to ask me.
Yeah. I'll send it to you.
Yeah.
Right after.
Fantastic. Okay. And then we will see you in 2026 for sure for our next round of rounds on medication for chronic phase.
Sure.
And thank you so much. Thank you. I'm sorry we're over time, but so many people joined. We appreciate it. We'll see you next year. We'll see you earlier, but then we'll see everybody next month. We have another fantastic round rounds on the third Tuesdays of the month.
Thank you so much for inviting, Clara. Take care. Okay.
Thank you for doing this while you're on service too. Thank you.
Okay. Thanks.
Okay. Bye everyone. See you next month.